Yes, sir. You can start.
Okay. So thank you. Welcome all. So we are starting again, and yes, dementia, as has been introduced by Sashiji, dementia in India is not a very popular topic, and whenever it is discussed, it is normally parked between two domains, as I have been telling. It is either parked in the domain of healthcare, or then it gets parked in the domain of social care. So when we advocate for policy, we are normally then sent from one healthcare to social care and social care to healthcare, and this kind of bit of confusion remains. So when we talk about policy advocacy, I talk from my own experience from ARDSI, where we have done policy advocacy at the national level. And when we did policy advocacy, we normally looked at a baseline, and then from that baseline, we looked at a benchmark. So baseline, I essentially mean like we assess the local situations as to where do we stand and what is the current position and how do we do this and what should be our ask. If we have to be clear about our ask, then we need to know about the situation in terms of health infrastructure, healthcare availability, and also the personal abilities. I mean, personal abilities means the ability of the current medical fraternity to diagnose these things at the right time and at the right place, and also the health setup to carry out the much needed care. So these are some kind of issues which we have been looking at. And then we pitch our ask. So when we are pitching our ask, then once again, we need to look at some kind of a ideal benchmark. So that ideal benchmark, as I have been always telling, we have been looking for, and in 2012, WHO declared dementia as a global health priority. And after that, in 2017, they came up with a dementia action plan, global health action plan, which had 7 action areas to look at. So this is the benchmark that we have looked at, but in reality, this is much of an ideal desire for us. So we need to juxtapose it with the Indian conditions and then make our ask based on the existing situation. So now we have two distinguished speakers among us who are just going to take us towards their experience and guide us to pitch our ask in a very clear way. So now I invite Dr. Chandrasekhar. So before inviting him, I would like to give a small brief introduction about him. Dr. Chandrasekhar has been a pioneer in mental health, and he is the founder and managing director at Asha Hospital in Hyderabad. He is a senior consultant in neuropsychiatry, and he has also additional specialization in geriatric psychiatry. He graduated from Tirupati, and he did his post graduation in MD psychiatry from NIMANS, Bangalore, and he was also awarded the Murthy Rao Gold Medal for the best outgoing student in DPM at NIMANS in 1980. He worked there and in many other places as assistant professor in Institute of Mental Health, Hyderabad, and Osmania Medical College till 1988. And he was also consultant to various corporate hospitals in Hyderabad. And he has been a pioneer in the concept of delivery of mental health care in all its dimensions, especially in the private sector. And Asha Hospital is now an accredited hospital with NABH credentials, and they are also offering the postdoctoral fellow program in child psychiatry. Dr. Chandrasekhar has been into teaching since 2006, and since then he has guided 20 DNB dissertations and 25 phase 3 and phase 4 clinical drug trials. His area of interest include neuropsychiatry, of which geriatric psychiatry is very close to his heart, and he is also a specialist in mental health legislation. He has been a guest faculty in many CME programs organized by state, zonal, and national level psychiatric programs, and he's the past president of Indian Psychiatric Society of Andhra Pradesh and also the past president of Indian Psychiatric Society South Zone and presently the vice president of ARTSI Hyderabad Deccan chapter. He is also the managing trustee of Chetna Medical and Educational Trust, which is in association with Institute of Rural Health Studies, runs the rural psychiatric services. With these things, I welcome Dr. Chandrasekhar to give his wisdom to us. Sir.
Thank you, Mr. Narendra, for that kind introduction. Um, having been taking care of patients or persons with dementia over the last 2 decades, there are certain of my observations which I'm going to present in the next few minutes. One of the important observations is that dementia cannot be relegated to a large tertiary hospitals or institutions. Dementia care is not in the purview of such large spaces. The second important thing is that dementia care is ultimately to do with community care. And the primary care physician is going to be the anchor. If at all we have to diversify the care of dementia into the community. Like any service has to be accessible, available, and affordable to a large section of the population. And how are we going to integrate this dementia care into the community is the central question of today's discussion. If you look at the process of care for dementia, generally it happens that the person or the carer or what we call the family member or sometimes the person himself suspects that he has got some cognitive difficulties or suspects that he's losing his memory and then approaches to the nearest doctor known to him who can be a primary care physician. Once the primary care physician suspects that there is a cognitive disorder or early dementia, probably he may try to do some basic investigations to rule out some common causes of reversible dementias and then refer this individual to a specialist care or a specialist center for confirmation of the diagnosis. The specialist, after doing some investigations or examinations, will definitely confirm the diagnosis of dementia. The whole process starts after confirmation what is the care pathway which this individual is going to take care of. This is where in the last few years, last few decades even, the fragmentation of the care pathway happens. What I mean by fragmentation is that after the confirmation of the diagnosis, the family or the individual are not guided what are the facilities available in and around. To a large extent, in fact, the facilities are not really available, but even what are the available facilities? Because dementia care is a continuous process. It doesn't halt at a particular point of time. The care is also usually depends upon the stage of dementia, whether a person is in the early stage or the middle stage or the late stage. So, and the protocols of care also keep changing depends upon the location of where the patient is on, depending upon the stage of the dementia and what exactly the patient needs. So the dementia care starts from the diagnosis to end of life care. Doesn't stop in between. So the whole process has to be charted out because once with the diagnosis of say Alzheimer's dementia, this individual may survive anywhere between 3 to 12 years. And how are we going to chart the path of this care? If you look at the national health programs, usually they are limited or not really, they do not cover so much on the rehabilitation or the palliative care or psychosocial interventions. It's very difficult to integrate psychosocial interventions, rehabilitative and palliative care into national health programs. As Mr. Narendra was mentioning earlier, a lot of times it's even difficult to know whether Dementia care is relegated to the Ministry of Social Justice or Ministry of Health. Sometimes it becomes a problem. Even the national mental health programs or the district mental health programs, though they were very tardy in their implementation. I remember the national mental health program was started when I was a student in 1982, and it has seen the light of the day somewhere in late 90s. And even now, not even one third of the country is covered with DMHP. So keeping that apart, the national programs with representative dementia are very sparse, and right now I don't think we are very comfortable with those programs. Now, having said that, there is a care pathway which we have to really look into. What is the model probably which we can think of? My whole idea is that there should be some decentralization of dementia care services. So if you want to decentralize, you have to relegate the responsibilities to some local pockets. So I tentatively call it as a dementia care trust for a defined geographic population, or what can be termed as neighborhood clusters. That will be the essential first step in providing the care. This trust should comprise representatives of families, local general practitioners, local health establishment, and representatives of NGOs who work in the area of elderly care. All persons with dementia in the specified locality must be registered with the trust. So anyone who is diagnosed by any primary care worker or a specialist or any health agency should necessarily be registered with this dementia or care trust. The process of recruiting persons into the dementia care trust can include surveys in elderly care homes in that locality, awareness programs in the community, awareness programs in the various healthcare establishments in the locality, including general practitioner clinics, clinics of alternative health systems, etc. Every person registered with the DCT will be attached to one of the GPs, one of the general practitioners in that locality. The DCT will coordinate the various stages and pathways of care by having on board various specialists. Depending on the stage of dementia, the care needs are assessed and appropriate services rendered. The locations of care can be the family, elder care homes, geriatric hospitals, general hospitals, palliative care centers, on hospice. The DCT employs dedicated care managers to take the responsibility for a group of persons with dementia. Maybe each care manager can have about 5 or 10 under him. Irrespective of the clinic or hospital where the diagnosis of dementia is made, the family is referred to their local DCT. Every family will be able to reach out to their care manager and the designated general practitioner. Where specialist advice, supervision, and service are needed, it is coordinated by care managers and GPs. The family is relieved of burden of searching around for efficient services, and the caregiver member of the family can focus his energies on attending to person with dementia. Thus, the carer's burden is significantly reduced. The DCT, let me again very categorically mention that when I say DCT or Dementia Trust, it is not a philanthropic organization. It needs to be adequately funded. The GPs, specialists, and other staff have to be financially compensated for their services. DCTs can source their funds from government grants, voluntary contributions, from families, and donations. And it is going to liaise with local primary care physicians, the general hospitals in the locality, the nursing homes, the specialty hospitals, and any other healthcare establishment which is involved with care of the elderly. Now, what can this? As I said, it is not a philanthropic organization, and persons who are involved with the care are adequately compensated. And several DCTs can be established across a city. It is not a single monolithic sort of a center, and several DCTs can be established across the community. And the staff of the DCT can be involved in various training programs. The training programs can be given by the ARDSA or by professionals, geriatric medical units of medical college, hospitals, and other relevant organizations. What I personally feel is What are the services which the Dementia Care Trust undertakes? It establishes the memory clinic in the locality. It is responsible to home care and home visits by the care managers. It can establish an activity center in the geographical location. It can also look into respite care and long-term stay. It also can look into palliative care and end-of-life care by liaising with the similar organizations in that community. So what I personally feel is that this sort of a model is definitely doable and sustainable. As the burden of care is shared, the person with dementia and the carer get the ultimate benefit in this model. I think this is one of the doable models which probably can be experimented with in some locality, some location with say maybe 2-3 lakhs population, and try to see whether this is scalable to a larger community. Because as I say, I keep repeating, dementia is a continuous care, and the family keeps faith in one of the care managers whom they try to contact repeatedly. This is what I find. There could be different medical needs, there could be different social needs, but they anchor themselves to a particular care manager. And this sort of a model, I don't know whether it can be integrated into the national health programs. I am not very sure. But what are the challenges of this sort of a model, which I try to put across? One is the traditional divide between the primary care, community services, and hospitals is a barrier in personalized and coordinated health services, which the patients need. In dementia, what we are looking at is the person-centered approach. This person-centered approach cannot be like scalable in a vast institutions. So it has to be smaller sort of a pockets of care. And as I again said, the dementia is a continuous process, and the care protocols need constant revision. The care protocols, even in a given case, needs constant revision. What I suggest probably this week may not be applicable after 2 weeks to the same family and the same patient. The protocols needs constant revision. Uh, Other thing is the collaborative care team, which is involved in the care, should probably acquire some expertise, resources, and manpower to meet the evolving needs. And the existing dementia care system may resist change. A lot of people will come and say, why do you need that sort of a model, so much of thing? Right now we are doing fine. Like we are diagnosing, we are telling the family what they have to do, and the family is taking care of it. In India, all of us know that the family is the ultimate carer. But ultimately, there are several families who look for other options in terms of respite care, in terms of palliative care, in terms of end of life care. So the families do look for various other options. Not that the families are ever happy taking care of their family members with dementia. I think this is I think somewhere we err in our perceptions. The same thing happens in chronic mental illnesses. We think that the families are absolutely happy taking care of their wards, which is not really true. A lot of families do look out for various sorts of help where they need help, but because the help is not available, they're desperate and they continue to bear with that burden in the family. So these are some of the things. Another important thing in this model is that because it is important to address the disappointments and frustrations of the collaborative care model staff, because they will be meeting with a lot of roadblocks. So how to get over these roadblocks, how to really integrate it, how to make the governments involved in this sort of models is one thing which I think all of us should discuss. Thank you.
Narendra ji, you need to unmute.
It was very visionary in a way to have your wisdom, and it gave us a very good kind of a model which can be adopted and mainstreamed across after testing it maybe on a pilot basis somewhere. And this is a very good model, and you also very well underlined during the start of your program that it should be accessible, it should be affordable and available easily. And you also juxtaposed the erstwhile mental health policy and underline the lacunas in that and the need for making it holistic, and your care models are truly visionary. So we will discuss on this further. And in between, I would like to invite upon our next speaker, Dr. Ramesh, sir. And yeah, so just I would like to give a brief introduction before handing over the responsibility to you, sir. So Dr. Ramesh is a very senior IAS officer from the Andhra Pradesh cadre, and he is at present the additional Chief Secretary to the Chief Minister, Government of Andhra Pradesh. So Dr. Ramesh graduated from Christian Medical College, CMC Vellore, and he joined IAS in 1985 and after his post-graduation in surgery. And he has served many bilateral, multilateral, and UN organizations. And he has 36 years of leadership experience. And he has served across the globe in all places almost. And to name a few organizations which he has been associated with includes UNFPA, UNOPS, UNDG, World Bank, and very befittingly, he was also the Principal Health Secretary of Andhra Pradesh for 3 years, and where he held the additional charge of Director of NIMS and also the Vice Chancellor of the Health University. And he has designed and implemented community health and nutrition cluster-based strategies for maternal and child health and nutrition integration with focus on community-directed action. And I think he is the most qualified person here to suggest us and guide us for a dementia national policy as well as a regional action. And he has also recently coordinated the efforts of contain and manage COVID-19 pandemic in the state of Andhra Pradesh. And he is united with Dr. Mani Madam and has two wonderful children who are pursuing advanced studies in Oxford University and Imperial College of London. So with this brief introduction, I invite you to share your wisdom, sir.
So, Mr. Narendra, Dr. Chandrasekhar, and Mr. Sashidhar, good evening, and good evening to everyone who's listening to this webcast. And first of all, let me congratulate you on the work that's being done. It's an extraordinary commitment, passion, and empathy that obviously drives your organization. And my hearty congratulations. And I also want to congratulate Dr. Chandrasekhar for his excellent presentation, summarizing a very complex treatment care model for a protracted and complex disease. So having said this, I mean, I'm not an expert, you're all experts, and then let me try to put it in a perspective as to how do we really, I would like to go ahead for next 40 years and look at what is likely to happen. One of the big changes that are happening in India, which has to be noticed, is the demographic transition. Our fertility rates are falling, and particularly in South India. And as you know, Andhra Pradesh fertility rate is 1.68, and it's been so now for nearly 12 years. So in that sense, the people are living much longer. As all of you know, when we got independence, the life expectancy was hardly 35 years. And today, the urban people are expected to live in state about 77 years, and maybe in rural areas about 68 years. So the people are living longer, and then this longevity is likely to increase. So people would live longer. The second one, what we see also is the increased proportion of people who are in the elderly age group. I mean, when I look at the census of 2001, in Andhra Pradesh, in the United States of Andhra Pradesh, there are only 4% people above the age of 65. And in 2011, it is 8%, and it's really doubled in that short period. And then, of course, by now it would be anywhere near 10 to 11% or maybe higher even. But significantly more women tend to be are surviving in Andhra state. So you can easily say about 65% of those above 65 years are women. And so I really see this as a problem because, I mean, you have a large number of single women, and in a state that is rapidly urbanizing. I mean, I'm just taking Andhra as an example, but this can apply to rest of the country. But India being so diverse, and each state is like a country because the subculture, the health infrastructure, the health services, and the way the people respond are very, very different. So, I cannot take up Kerala model and say I will apply it to Uttar Pradesh. I mean, you cannot even apply it to Andhra Pradesh, but there are a number of lessons we can learn and adopt. So I'm just trying to say that, we have an urbanization which also leads to nuclearization of families, which again shifts the children, the family away from the elderly age group. So we have a number of things that are likely to happen. So people living longer and higher proportion of elderly people, and then obviously better and how the prevalence rates of dementia and Alzheimer's and the related ailments would continue to grow. Now, when we actually, I mean, I was instrumental also in bringing about the focus on non-communicable diseases, and a separate program was launched by Government of India as part of the NHM. Uh, we really never. I mean, the thought that dementia should be included as part of that really didn't cross our mind. And so was also, I was associated, there was no more health secretary in finalizing the mental health care legislation and the strategy thereof for the nation. Uh, and there again, I think, as some of you have pointed out, these critical elements have not really been uh, taken cognizance of. Why I'm saying all this is there's a very little awareness at the bureaucratic level. Uh, Forget about the political level, but certainly at the bureaucratic level. Because I mean, I know that many of you are engaged with the governments both at the national level and state level. But what happens is the bureaucrats move on, and in the absence of an active engagement and active pressure, because the apart from you and associations or entities like yours, there is no demand really that comes for attention from the government. So what I would like to submit is a lot more advocacy is really required, because the governments on their own cannot really be cannot involve and deliver services for an ailment of this nature, which is very family centric and protracted and requires compassion, commitment, and long term interest. So, what I would like to believe is really this requires a larger societal awareness as well as the commitment of the governments in a substantial sense. I mean, let me put it much more clearly. Is first and foremost, I would like to believe that this awareness is to come at the societal level, at the family level, at the government level. I think media today can play a very important role. The electronic media, because I see a number of sponsored programs, and I'm sure any television channel would like to hear, and I'm sure there must have been. But I think these are things that require constant reinforcement for the family to be aware to seek extra care. And I refer back to my own personal experience to 40 years ago when my grandmother, my maternal grandmother, we used to go to her village on summer vacation once a year. And then I had seen a continuous deterioration of her from just being forgetful and being lethargic. I mean, she was a very active woman. She was very engaged, very loving, very caring person. But I've seen over a period of 10 years that she couldn't recognize us. So I have as a little boy, I have a very vivid image of this, Now, it not always people recognize that. In those days, of course, I mean, nobody really diagnosed when she was taken to hospital. They said, she needs to take vitamin B complex injections once a month and take tablets. So, I mean, obviously now when I look back, I mean, when as a medical student and as a doctor, when I look back, I knew that my grandmother must have had a dementia process. So, since this requires a larger engagement of the individual, family, and the society at large, and the community's commitment, and recognize that this is not a stigma, not something to be stigmatized, because particularly in our society, we tend to stigmatize people that are outliers or the problems that are not, they are subtle, that takes time to surface, that cannot be recognized immediately. So I really would like to believe that doctors, the entire treatment of dementia needs to be mainstreamed into the public health system. And I think this is important. It's important right from the time the medical student is introduced. I mean, I had as a medical student, Vellore has a much more robust training in psychiatry, but geriatric medicine was never a part of even a advanced center like CMC Vellore in 70s and 80s. What I'm trying to basically get it is that at least an introduction at the MBBS level, both on the nursing side and the medical side, because there are going to be a lot more reforms in the coming days. As you know, the new medical NMC has been established, a commission for in the place of old MCI. And I think this is an opportunity also to look at a curriculum reform for the medical education, in which some of these chronic NCDs need to be mainstreamed into the education. So at least there's an exposure, if not a con. So I do believe that with a major expansion in the field level functionaries, now at a village level today, we almost have a, a auxiliary nurse midwife in every village. So I would like to divide this whole paradigm into rural and urban. So we have a fairly sizable presence of the health functionaries at all levels. It may not be well known, but every 100 families have an ASHA worker, and these ASHA workers are periodically trained. And so these people need to be sensitive now, because the difference between a trust or an ARDS and government is government has can take anything to scale, provided it wants to do so. It can take it to scale, and we are a large country. I mean, we are 140 crore people, and we are scattered across 6.5 lakh villages and thousands of urban centers. So to take this, you need the government to have at least awareness, if not the commitment. So I do believe that now again, the elderly care is divided in the central level between the Ministry of Health and the Ministry of Social Justice and Empowerment. Now, at the state level, they are still integrated. I think the engagement with the states, and the health is essentially a state level subject. So, what I would like to urge is to work with the state governments, and particularly state governments that are a lot more sensitive. And I certainly would count Tamil Nadu in that, and any of the South Indian states. And the Western states are tend to be a lot more sensitive. So also is the North Indian states, but the capacity does not exist. Now, what it does, I mean, the model, the trust model that Dr. Chandrasekhar put up, I think is an excellent model. But how do we really mainstream that into the system? I mean, you do need an independent trust, an autonomous trust that can get, I mean, a trust which can really get financing, because ultimately you need funds, you need manpower, and you need the processes that are established. So the trust can then get money from the government, from the private sector, from the CSR funding, and from the people themselves, or the families, or the communities. So this together can create the nucleus, and that nucleus can be at the district level, because in Indian bureaucracy, the district collectors tend to have much greater leverage at the district level all across the district because they have all the machinery of the government works under their control. So I'm not saying the district collectors manage it, but the district collectors be a part of this. This be set apart from the government, really a trust that is managed, but it is integrated, or at least it has a organic link with the government. And so what does it do? It really helps us build, identify people very early. That's exactly what you need, that earliest possible symptoms, because you have this large number of health functionaries who can be trained, who can be exposed, who can be sensitized, so that they go back to the households, work with the families, and then escalate the person to the primary healthcare physician, that is a PHC level, and then to a psychiatrist or a neurologist or whatever may be appropriate for screening, so that there is a treatment protocol that is set in place. So then the management becomes easier. So this organic link between the government, the private sector, and the society and the community and the family and the trust, I think then you have a quadrilateral relationship that really anchors this management. The second part of it is the institutional care. I mean, either a home-based care is what I suppose you address. And then if there are institutions that need to be set up, and I do believe that there would be increasing need for them as we go forwards. I mean, as I said, the families become more nuclear, and so the less and less is the attention that we receive. This needs perhaps an institutions, and these trusts can set up those institutions. Now, I also believe this is the opportunity. Actually, we are also, as a nation, are transitioning from the traditional general nursing practitioner, what they call a GNM, to a more BSc nursing. And this would also mean specialization. So you would have, and also there is a talk about paramedical professionals as a intermediate tier. Now, these people could be specialized in this sort of caring for caring for these chronic diseases like dementia, the end of life care, the palliative care. And so you will have a larger number of professionals available. Today, you really don't have those. I mean, who can go and provide health, the assistance at home. I mean, really trained, professionally equipped, and those who could be supported. So, what I would like to say in conclusion, going forwards, and let's look forwards to that there is a need for an institutional mechanism, because as this would be a growing problem, this needs engagement with the government, and governments are convinced when you articulate this in terms of the cost to the economy, the cost to the GDP. I mean, in the sense, loss of productive years plus the cost of care and cost of support care, and the caregivers' loss of the time invested, and if it is monetized, we are talking about crores of rupees, hundreds of maybe thousands of crores of rupees that are lost, or that need to be compensated. So that's why there is a need for an investment. Then there is also, when articulating to the government, I mean, this requires the political commitment, and I think this is where bigger events would help. So in end, what I would like to propose is this is an important problem. It needs to be recognized as an important challenge that needs to be addressed in a sustained basis. It needs people to come together, and of all sectors, whether it is government, it is the not-for-profit, it is trusts like ARDS, it's the professionals, the private practitioners, the private sector, corporate sector, and of course the government, both at the political, bureaucratic, and the professional levels. I mean, a coalition of this becomes, and then this requires a longer term plan. This obviously is an incremental process. Without the government's active participation, it's very difficult to scale up these, because the governments have the resources, they have the machinery, they have the manpower, and all the lack really is the commitment, consistency, policy, strategy, plan. Now, this is where I think there's a big role for the organizations like yours to come forward, and people like me, I'm sure, are always prepared to step in and help and facilitate. But I think this is very important for this engagement to be sustained, because what happens is in the government, people lose interest. And then normally, what happens, if I were outside the government, I would feel very frustrated dealing with the government because I need to go back and forth several times. So that is why I said that it is important to set up an institutional framework at the district level as a trust, which is autonomous, but nevertheless, government has a role. Get involved. The collector can be a member of this trust or a trustee, so that there is a buy-in at the district level. Now, national level, I'm sorry, just I'll mention one. I'm sorry for taking time. I'll just take 1 minute to speak about the national level. It's very important for a national commitment, because if the national level, if the prime minister can be bought into this, a message goes across to the nation that this is a very important thing. One reference to the issue of dementia could have a long impact, because it goes all over the country. But don't anything less than that is not really going to have great help, because the states don't buy into the states have their own priorities, their own ideas about what needs to be done. So many secretaries of health, our chief ministers, our health ministers may not even be aware of the dimension of the problem and how important it is to address these issues, because it would have a transformational impact on the way that we treat our elders, those who are senior to us, and any one of us could be in that position. I mean, this framing this in a way that is attractive enough, compelling enough, and the sense of urgency, I think, is what would perhaps help address this problem in a much more comprehensive and sustainable manner. Thank you, sir. Thank you very much.
Thank you, Dr. Ramesh. That was really icing on the cake, adding to what where Dr. Chandrasekhar left. So, but you just took us through the entire spectrum of why we need to look into this, right? Starting from the demographic change which we are experiencing, and the longevity that we are facing, and your own contribution to NCDs, and where you somehow didn't realize that to include dementia as a problem. And for that matter, let me just tell you, like when this NCDs came into being, there are 5 risk factors which were discussed, and only 4 were included. And the left out was very obviously the mental health angle of it. And mental health very recently got included. Like last year, we had a UN convention in 2018, I suppose. I think 2018 there was a UN meeting where they included mental health into this, and India was one among the first countries to have its own NCD plan, and for which they were given an award also. And JP Nadda was receiving it in 2018 in the UN. And you also spoke about the lack of awareness, and also the commitment of the government, and the utility of media, and also the need for integration of this problem of dementia and knowledge of dementia into medical curriculum, and training medical as well as paramedical professionals, and your advocacy to also have specialized paramedical people who has specialization in geriatric nursing, and then having something as a GNM, general nursing people, and also the possible role of ASHA workers, because we need to also cater to the rural population. 2/3 of the country lives there. And the model of Dr. Chandrasekhar, how well that can be put as a quadrilateral mechanism, where we can have this particular thing functional and working with the essential functional integration elements into that. And thanks for that, sir. And also, finally, you concluded with the value point of why should we be also valuing our elders as a very telling force, because we are also going to be there in some point of time. So thank you so much for very well summarizing the need and the need for policy inputs. And also you underlined that uh, a very important aspect of loss of caregivers time. And you would be very surprised and happy to note that ARDSI is partnering with London School of Economics and NIMANS, and we are essentially working on a project called Strengthening Responses to strengthening responses in India, especially related to developing economies. So we are just working on the unpaid carer cost angle as well as stigma. So both these angles are very well looked into, and this project is going to bring us a lot of data, and this data can be fed as very good policy inputs. And you also talked about loss of productivity and the need for a political commitment, and also the awareness which has to be there at the bureaucratic level. Thank you so much, sir. So now I would like to add some more points and the efforts done by RC at the national level. So I would just want to add upon that. So when I started, I said we need to have a baseline and a benchmark, and also we should have a policy. When we talk about policy, then it is only an explicit intent that we are talking from the government. Just a policy alone is not going to serve the purpose. So when we are talking policy, then it has to be given life, it has to be given some kind of power. So the life is basically in the form of an action plan. And when we talk about action, then this action should be supported with allocation of budgets. So this normally doesn't happen, because when I was part, like in my introduction, Sashiji said that I was part of two sub-work committees. So we did work during the 12th five-year plan, and we were asked to make a presentation in front of the Parliamentary Health Committee, and then also we made a presentation to the Planning Commission. Then we made a presentation with the Health Ministry, and when we were doing this, Health Ministry immediately suggested that we should include dementia into that. And when we included dementia action plan into that, that was made part of that whole recommendation to the Planning Commission. But unfortunately, there was no budgetary allocation to that. So when we talked about creating awareness, then that awareness should be piggybacked on that what you call Panchayati Raj budget from Panchayati Raj, because Panchayati Raj has a provision for dissemination of information, so that should be utilized here. So this way, no clear-cut specific allocation was made for caring for dementia. But eventually, then that didn't see its light, and the next government came, and the whole setup changed, which is history now, and you know that. So now I would just go through a small slide of my own, and just take you through the journey that ARDSI has been into. So yeah, are you able to see my slides, sir?
Yes, yes.
Yeah. So yeah. So this was the Dementia India strategy which we had made in the year 2018, and this was presented in a dementia conference which we had in Bangalore to the health minister. You can see the health minister unveiling our plan. This strategy report talked about the local situation, like as of today, because that day it was 4.4 million, and today 2020 we are, and the figures have revised to 5.29 million people living with dementia. And this was basically also having data like the diagnosis was only 10%, and there was lack of experience and knowledge among care professionals. No specific care support at all levels were present. and no social security concessions were envisaged, and there has been a high care burden. And when it came to Andhra Pradesh, by 2020, we have at this point around 4.61 million people living with dementia. So this is our Dementia India report statistics. And this Dementia India statistics, I would just give a small background. In the year 2010, ARDSI conducted a countrywide workshop. Like we had four regional consultative meetings, and in all these regional consultative meetings, we engaged people from Niman, people from AIMS, and people from other medical institutions, as well as the carers, and also some other practitioners to come together and discuss about this problem. And we took into account all those considerations and concerns which were expressed, and we collated the data with the existing studies whichever have been done in India and extrapolated the data on the Indian geriatric population, and then reduced to this kind of figures, and we had a statewide prevalence. And this formula was based on King's College London, and Professor Martin Prince from King's College London helped us in deriving this data. And now this is being referred to as a Bible, both by ICMR and also in Parliament debates, that whenever we talk about the numbers, this is referred to as the Bible. Now, how is it globally looked at? So WHO global yardsticks are like this, as I have been talking about the global plan. So these are the 7 action areas where they have suggested action. So they say that dementia should be made a global health priority, and there should be actions which should spread awareness, as you rightly pointed out, and that the action should be more towards friendliness, creating friendly environment. Like Hyderabad, ARDSI Hyderabad has been a pioneer in doing that. Last year, they had many kind of events where they went ahead and sensitized people in malls, people in public places, so that any person with dementia, once they enter that environment, so that whole environment is friendly to them and they are conducive, and they don't find that they are into a new place, and they are treated with the same kind of love and affection. So the third area is dementia risk reduction, and the fourth area, dementia risk reduction, you have already covered. Like we in India, we have an NCD policy. Even if we implement 25% of that, so that is going to greatly contribute to the risk reduction. And recently, the Lancet Commission report has suggested that 40% of the cases can be reduced if we practice some very marginal lifestyle modification, like not smoking, not indulging in any kind of drinking, and having a non-sedentary lifestyle, and also checking the vitals and keeping it under control. So these kind of basic things can reduce to the extent of 40%. And then the fourth one is dementia diagnosis, which we have been talking. There has been only 10% of diagnosis possible, and treatment and care support has been very, very minimal. That is predominantly because that India's culture is about not taking people to institutional care, but they prefer to keep them home. And long-term care, when we talk about, it starts at home, and it is popular to the contrary belief that whenever it is discussed abroad, they take long-term care as institutional care. But I keep on advocating that long-term care, once anybody who is subjected to a 6-month continuous care should be taken as long-term person qualifying for long-term care, and long-term care starts in India at the family level. And support to dementia carers was another element which we wanted as part of this global action plan. And then information systems on dementia and dementia research and innovation. So these are few action areas with the global plan got to us. And we, when we looked at it, we just Indianized it, and we said that public health priority is okay, but we would look at dementia awareness as the second line of priority, and risk reduction as the third line, and we put the information system last, and then dementia research as the last button area. Rest of the thing we retained as it is. And then So as I told you that we already had this journey, and India had already been done the groundwork. And here, two important things which I would want to say is that ARDSA is already collaborating with Kerala state government, and we are already implementing a model which is known as Kerala State Initiative on Dementia. But here I would have to submit that this model is predominantly taken care by two institutions. One is Kerala Social Security Mission, and then Kerala Social Welfare Board. Both these institutions have come forward and they are taking care of this, and four components are getting addressed. One is that like this particular thing is to raise awareness among the general public, and also put forth very lucid messages in websites and other prominent places. And the second thing is that train their healthcare professionals. And the third one is run services. And the fourth one is, rather, the third one is to provide SOPs, like standard operating procedure for daycare, for running of full-time care, and also setting up of memory clinics to ensure diagnosis. And the fourth one is, of course, running of services themselves. And Kerala, as you rightly said, we can't take Kerala model or Goa model as an example for a larger state, because it is administratively very easier for one to implement programs, because you only have 14 districts there in Kerala. Most of the time, I always hear that people talk about Kerala model, and Kerala model doesn't definitely has a lot of advantages, and it has also a cultural sensitivity, so which may not be the same case in other states, but we can definitely draw, as you rightly said, the positive experiences from that kind of model. And here, 14 out of 14 districts, in two districts, we have already established full-time care, and the first of its kind model is in Edavankad in Cochin. So where we are running a full-time care center, where an existing old age home has been converted as a dementia care home, and here people are cared free of cost, and they are cared 24/7, and the standard operating procedures have been given by ARDSI National Office, and ARDSI National Office serves as a knowledge partner in this KSID project. So similarly, we are also running a daycare center. And the other government which has come very close to implement something tangible has been the Maharashtra, government of Maharashtra, where the health ministry, they themselves have addressed the problem of diagnosis, and in 6 districts they have piloted this. And we have also, as I told you, that we are engaged in STRIDE project with NIMANS and LSE, and which is also looking at the carer aspects. Now I come to the Dementia India strategy. What did it entail? As you have seen those 7 action areas. So we said at least 30% of the Indian states will have their own state program, and we wanted to put this and bind this to a timeline. And we said that when we stated awareness, 80% of the states where NGOs like RCA as chapters will have at least 80% of awareness, and there will be a campaign, and 50% of the states will have at least few dementia friendly initiatives, and 50% of the states will have stakeholder specific sensitization guides and manuals in place. And when it comes to dementia risk reduction, it simply took over the mandates of NCD program, and we said that premature mortality reduction from NCDs should be reduced by 25%, and alcohol consumption should be reduced by 10%. These are all Indian figures. This has nothing to do with the global action plan. So this, we just went through many kind of publications and then research papers, and then we came up with this kind of recommendation, where we were also talking about reducing sodium intake, reducing tobacco intake, like use of tobacco, and receive drug therapy and counseling to prevent heart attack, and improve availability, affordability of NCD medicines, and reduce indoor air pollution related to solid fuel, because even air pollution has been seen as a very potential NCD threat for getting dementia. So then dementia diagnosis, we wanted to increase it from the erstwhile 10% to 30% in the states, and 40% in the states where RC is present. And similarly, 30% of the states we wanted that there should be full-time care centers for advanced stage patients, and then we wanted 30% of the capacities of the GPs and the paramedical staff should be built in, enhanced, I would say rather, and support for dementia carers should be raised by 40% in all states where NGOs like ARDSA is there, and by 2025 this should get achieved. So this was the ideal kind of a plan that we had presented to the government. And dementia research, like there should be more research in terms of effective therapies, in terms of what you call very like patient-centric care and the models which Dr. Chandrasekhar was suggesting. So there should be dementia research done on this and its effectivity, and then mainstream. And then we should also have a, like we have cancer registries, we should have dementia registries, and at least in 30% of the states, they should come into action. So then these are the key asks that we asked from the government, national government. We said based on our recommendation of the draft strategy, let an expert committee be formed and dementia country policy with a strategy and an action plan and budget allocation be drawn. Then we also suggested that to ensure early diagnosis, they should take up the ARDSA memory clinic model, because we have come up with a guideline, and this guideline, as you know that now the current government has a mandate to, as you rightly said, at the rural most level we have sub-centers. All these sub-centers are now being converted and re-christened as wellness centers. And these wellness centers, NHSRC, National Health System Resource Center, has a model now to ensure mental health care at the primary level. So when mental health care can be provided at primary level, then we said that this telemedicine innovation should be taken into consideration, and ARDSA memory clinic guidelines should also be put in place, so that wherever there is a larger population and a larger elderly population, there this kind of thing should be explored. And we consulted NHSRC, and NHSRC took our manual, and they said that they will try it in few states like the advanced state like Maharashtra and Andhra Pradesh and other places. And similarly, they said we asked for convergence, because there are so many national policies which are there, and they are all working in silos, and they are not having any kind of intercoordination. You ask for an elder care policy, on paper we definitely have the most beautiful policy. We have a national program on healthcare of elderly, and when you talk about national program of healthcare of elderly, we have a mandate of having 100 districts covered to have geriatric clinics set up. And if you ask me the position as of 2018, it is only 36 clinics, 36 districts which have complied to this provision, and rest of the districts are still putting it into action. And similarly, we want to also have convergence in terms of national mental health program. When we went and advocated with the government, in the central government, we were told that only 200 crores of allocation has been made for district with this whole mental health program. But when we interacted with National Health Mission, then we bumped into almost a gold mine kind of a situation, where they are telling that 83.20 lakhs is available under district mental health program allocated, and 700 odd districts have been given this provision. But we can't just spend this money unless and until the DPR has components of this district, some kind of mental health initiative as a component, because predominantly all DPR, they come only with something related to reproductive health, something related to tuberculosis, something related to HIV and AIDS, something related to vector-borne diseases. So all these things relates to communicable diseases, and non-communicable diseases is nowhere within the agenda of the DPRs. So now our ask is that all these DPRs should invariably include something, and if anything at all comes under district mental health program, it all relates to something relates to autism or epilepsy. Nothing of the sort of comes in terms of dementia care. And similarly, we wanted to also recommend and mainstream dementia in other ministries so that elderlies get some kind of concession as cancer patients and other people get concessions in terms of transport, concession in terms of privileges in other sectors, and also enhanced pension and other things. So similarly, we also said that we wanted the paramedical staff and medical staff capacity to be built up, and there need to be more care workers who have to be especially like exclusively trained in dementia care, because dementia care is not geriatric care. Dementia care requires a very specific and very specialized care. These were our asks, and we had put them in a very good document and presented to the ministry. But we are yet to hear on that. And now we are once again back to this National Health Mission, because National Health Mission is a national program. So the implementation happens at the state level because health happens to be the state subject. And as we have the provision for district mental health program 83.20 lakh, now we want the states and the districts to come up with DPRs by including the first thing, like the first thing is the diagnosis. Because once we know that somebody is affected with dementia, then the whole process of care can start. Unless and until a confirmed diagnosis is not there, then we are somewhere stalled. So we wanted this memory clinics to be put up, and which hardly cost 20,000 rupees to set up. And if a person, to the extent of a multi-purpose worker or a social worker or even a clinical psychologist is empowered to man that particular thing, it is collectively going to cost the government only an yearly cost of around 3,60,000 rupees. So 3,60,000 rupees, if you have provision, that can run a memory clinic for 12 months. So DPR should essentially include at least provision for this, and also they should have this handholding model of what Dr. Chandrasekhar was telling about, because at least in piloting in each state, if we can have 5 or 6 districts having this model working, so we can definitely see that this quadrilateral mechanism of having supervision, support supervision of the CMHO and the district collector, because CMHO is the real official head, and they are put in tandem with the health mission staff. The health mission staff are manned with district program managers, and these district program managers should man this and then see this, that this kind of thing is happening, and a referral mechanism has to be enabled. Once the referral mechanism is enabled, then the treatment can be done in this dementia care trust, which Dr. Chandrasekhar has been suggesting. I think I would end here and like to know your views about, and we will take forward the discussion. Thank you so much. So over to Dr. Ramesh, sir, because you are
Okay.
from the government, and I
No.
want you to tell us and guide us to take us forward. How do we
No.
realize this on ground?
Doctor, I think, I mean, to all of you, it is an excellent presentation. But I think one observation I have is it seems too ambitious to be. It's too ambitious because we are really starting from a situation where we have um, you've done a lot. I mean, your advocacy, the way that, you're able to actually start with a plan, they have a strategy and get the national governments to buy in, set up standards and set up benchmarks and all that. This to be, I mean, first of all, I think our expectations need to be moderated. Number one. Number two is you really need to work with the states. If you or like-minded NGOs or whoever is available, I mean, the people. I mean, you always have advocates who will join you. I mean, those who are I mean, who may not be currently part of your organization, but I'm sure people like me would like to chip in their best to see how we can actually craft a plan. So that's the first point I want to make. Second is, I think you need really a state level buy-in. The states need to come on board and say that we have a commitment, and state governments, and then you initially start working with those states, and so the others will also come on board. I mean, if you have one state in north, one in west, one in east, and you already are there in Kerala and other places, and if only they can be incrementally stepped up, I think that would be second. Number three is, it's critical really to have the district collectors buy-in. I mean, if you have district units or your state level people could have a partnership with the districts, I think it's very important that ultimately action happens all across India, at the district level. I mean, we are able to do whatever, or we fail to do whatever with reference to COVID. It's largely on account of the leadership or the lack of leadership of the district collectors. I mean, everybody chipped in. I mean, I'm not saying that, we are very individual driven culture. There's a good people, there are bad people. There are no good institutions and bad institutions. Our institutions are what they are. We can't build them overnight. There are good people who have the commitment and the concern, and we need to nurture on that. And so I do believe what Dr. Chandrasekhar suggested as the trust, a district level trust would be useful, because, and I really like your idea of a registry. Now, I mean, we've been talking about a cancer registry for years. In fact, when I was health secretary 10 years ago, that was, I mean, it seems like ages back. And I was also simultaneously director of NIMS. So, we could start the process of using NIMS as the registry keeper. But, something started. I mean, this is the way the things start. It may not pick up everything at our country, but, we need to start. And I really admire your commitment and concern, and also the comprehensiveness of your plan. That if this can be translated, I'm sure that in Andhra we will support you in whatever way. Now everybody's resources are consumed by COVID management. I don't think there's a much of a space anywhere for anything other than COVID. But I'm sure time will come soon when we can move forwards with other things. With this, I mean, if not now, after 6 months, I think this is, I mean, I do believe that it will be a year before actually things stabilize. And during this year, it would be acute problems that would, I mean, acute non-COVID problems that would consume the attention of the healthcare system, whether it's private or government. So I do believe that this is a good time to consolidate, to work what we can do in the desk level, what you're doing now, in terms of thinking, strategizing, networking, communicating, and bringing a collective action together, an action plan. So much of the desk work needs to be done now, and can be done and must be done. And much of the networks can be built, people can be roped in, partners, those who have similar interests, the coalitions can be built. And this can be rolled out once the system stabilizes, because I don't think anybody is in a position to listen in the government to anything other than the active problems. So I think this is a very good time to start thinking on this, building frameworks and the models and the covenants for the trust, what ought to be its composition structures. I mean, I think it has a huge opportunity. Dr. Chandrasekhar, what he has said, there's a lot of it inbuilt into those 3 slides, and I think that's a way to go forwards. But unless we mainstream this with the sub centers or the health wellness center and PHCs, and then of course bring in the private sector, it would be difficult. But this is something important. People need to know about it. Use the media, social media, electronic media, print media, write articles, appear on the television, talk, uh, catch hold of the important opinion makers, whether it is film actors, they are the rock stars, the cricket players, yeah, the big political leaders, And Prime Minister once talking would mean a very big differential in my view. So these are some of those things I believe needs to be done. And my personal and professional commitment will always be there. So anytime, anything I can do, I would certainly chip in. And anything I can facilitate, I mean, I may not do, but I can certainly facilitate. And to such an extent, I will be at your service. Thank you very much, sir, for inviting me and giving me this
Thank you,
time
sir.
and this opportunity.
Dr. Chandrasekhar, your views, sir.
I always believe in starting something small and then scaling it up. I still feel that at each local level, we have to build up these small units of care and try to have a link between the local general practitioners of the areas. Unless you integrate that and give confidence to the primary care physicians that they can take care of majority of the work which we are doing, we will be at the back to support them. Then there will be a lot of things can be worked out. I think somewhere along the line, what happened is we relegated to the awareness programs to the general public. We never took care of the general practitioners so much in the awareness programs as ARDSS, some other things. Somewhere we are focusing on various general public. I think that is good. General public should be aware of the problem. That is, I am not saying that it's less important, but more than that, I feel if I have say 100 general practitioners in the city who will listen to me, and when a person comes say from one particular area, and I tag him to the local general practitioner, saying that these are the things which he can take care of. These are the things which are needed for you. It could be with reference to feeding, or it could be with reference to their bowel needs, it could be with reference to their mobility. All those things can be worked out in much more cohesively. And once we start with the small groups like that, these such groups will expand. It is something like I tell you the Rotary Club and Lions Club phenomena. Initially, we'll have one for the whole city, then they will start for one each locality, and the network. Something like that. These networks should be built up.
Thank you so much, sir. Sir, I would just conclude with 3-4 remarks. One remark is that when we talk about public policy advocacy, there is a popular belief that public policy should only be done with the government. So I'm really against that, because at this point, at least we need to also go and sensitize the corporate people who are, like you were telling, at this point, we are also not having, we are crunched with resources. So if that is the case, then we should also think about advocating with the corporates so that we bring in elderly care and dementia care into their agenda. So that kind of advocacy should also happen. And for that kind of advocacy to happen, I think government should also put a small kind of somewhere a word. Like yesterday I was hearing somebody in the parliament, and then I was, though without taking any sides, there was something like some allocation of CSR funding is there, but that is predominantly into certain kind of focused areas like education and other things. But even healthcare, it is more once again rooted to the what you call the productive age group, and elderly are commonly seen as a spent force. This mindset has to go, because that is one thing which I just wanted, like when you are about to plan for something for elderly, then you should have all these things into consideration, and you should put a word to corporates that they need to allocate some of their portion of their resources even for elderly care. Unless and until we do that, all corporate are more focused towards education, and the second major focus is health. Health, when we talk, they are more into reproductive health and nothing else. So this is one request from my side, and my ask to you, because that you represent Andhra Pradesh government, I just wanted to ask, like, you should categorize your districts with 15 lakh and 5 lakh population, and try and implement the NPSC provisions there. That is one thing. Second ask from my side is that at least you should identify 5 districts for us, and include memory clinic guidelines and setting up of memory clinics there, and ensure diagnosis at least in 5 districts as a first year program, and in second year, you should motivate the social welfare board to include provision for setting up of dementia full-time care centers under national program of elderly. There is a provision of 26 lakhs per annum for taking care of 25 people, and there are provision for dementia, setting up of dementia care home. So this is not widely used, and I think the social welfare board setups in districts should be motivated to take this assistance and realize something, some structures on ground, and maybe there we can set up these trusts which Dr. Chandrasekhar has come as a model. And now, just to sum up, I would say that we, as I go by what the wisdom of Dr. Chandrasekhar, he suggested that we should be on a pilot basis. We should start somewhere small and consolidate our experiences. Once we consolidate our experiences, we need to standardize them and then mainstream it across the state. So thank you so much, sir. And thanks for being part of this very wonderful journey and guiding us with your wisdom. And policy advocacy, as I told, doesn't only engage us mean that we should engage with the government. We should engage with stakeholders. We should engage with corporate. We should engage with all donor communities and sensitize them and bring elderly care and dementia care into their agenda. Otherwise, then it will only be a one-sided effort. Thank you so much, sir.
If I may just say one thing, Narendra Garu. When I was, before coming here, I was chairman of the REC, and I had given 20 crore rupees to build, the elderly care homes, and so for the elderly care for different NGOs. One of them is built in Leh. So I'm very proud of that, the first. No, there would be any number of people giving funds. Actually, is not a problem. We just have to knock the door. I mean, if I had known just 2 years ago when I was in Delhi, I would have given a 10 crore check to you. So, but
come fast to Delhi again, sir. Maybe on
and I have two more things. I mean, one more thing is, I mean, this at the central level, the Ministry of Social Justice has an important role, and of course, I mean, it goes to the social welfare boards is certainly an important thing. The ministry, I think, ultimately at the state level is the Ministry of Health that takes an important role. I think somehow the engagement should be with the Ministry of Health so that they can in turn take advantage of whatever funds are with the social welfare board. I mean, I'm just telling you from a factual point of view, but wish you all the best, and it's a great work. Keep it up. But this is the time to consolidate, consolidate, and compile.
Thank you so much, sir.
Thank you.
Over to Shashiji with your concluding remarks.
Thank you, sir. Thank you, Dr. Ramesh Garu. It's been an amazing, interesting learning session for all of us. Dr. Chandrasekhar for, I think, bringing about the most practical aspects of where we are today and where we need to get to. And Narendra Garu, an amazing job. Thank you so much. And on behalf of ARDSI Hyderabad Deccan Chapter, firstly, I'd like to thank each one of you for your time. And we hope that we will get an opportunity to work with each one of you individually and bring you on board. Thank you so much, and have a nice day.
Thank you so much.
Thank
Love
you
to all of you.